So welcome everyone to FSR's webinar on advanced pulmonary and advanced cardiac sarcoidosis. Before we get started, we have a few housekeeping items. Today's event will be recorded to allow you the opportunity to return to the important information that you will learn today. This program will be in webinar format, so your lines will remain muted throughout. We encourage you to place any questions that you have into the chat box at the bottom of the screen and just type those notes in there. We have a fantastic program for you today, and so without further ado, I am pleased to introduce you to FSR's CEO, Mary McGowan. Welcome, Mary.
Thank you, Tricia, and welcome everyone to today's important webinar discussion on advanced pulmonary and advanced cardiac sarcoidosis. We have heard you, and we know that a better understanding of pulmonary and cardiac sarcoidosis is a top priority for our community members. We have had an overwhelming response to this discussion, with over 600 community members registering to join us today. We know how challenging it can be to live with a sarcoidosis diagnosis. We are proud to provide you with this webinar, as well as other resources to help you navigate this journey. I would like to extend our sincerest gratitude to our partners and sponsors for today's discussion: ANI Pharmaceuticals, Kinevant Biosciences, and Mallinckrodt Pharmaceuticals. We are grateful for your ongoing support of our efforts. I want to take a few minutes to share information about FSR for those of you who are new to the community and share some updates for those of you who are ongoing community members. FSR is the world's leading international nonprofit dedicated to supporting and educating patients and advancing sarcoidosis research. Our mission is to improve patient outcomes, find better therapies, and eventually a cure for sarcoidosis. We have a five-pronged approach to what we do. We accelerate research through funding, advancing and supporting clinical trials, and through FSR-led research efforts. We educate and support clinicians through networking, provider-facing educational programs, and collaborative efforts. We have a number of support group programs, as well as one-to-one peer-to-peer support program through our Patient Navigator initiative. We provide extensive education through webinars, infographics, podcasts, and even an international virtual 2-day educational summit, which will take place again next spring. And we advocate on Capitol Hill with the NIH, the FDA, and legislators to improve access for all. On this slide, you will find our small but mighty FSR team that is here to support you on your journey. We are led by our incredible board of directors under the leadership of our board chair, Mary Cobb. All of our scientific and educational materials are vetted through our esteemed Scientific Advisory Board, known as SAB. Keep an eye later this week for an announcement of our newest international SAB members who will be joining this esteemed board of leaders in January. After today's session, we encourage you to review the resources FSR has available on pulmonary and cardiac sarcoidosis. We will drop a link in the chat where you can find more information, including infographics, videos, and other educational webinars that might be of interest to you. Just 2 short years ago, FSR launched the FSR Global Sarcoidosis Clinic Alliance. The Alliance is a member program consisting of clinics, hospitals, individual providers, patients, and caregivers committed to finding a cure and offering evidence-based patient-centric care for those living with sarcoidosis. This program is aimed at improving the outcomes of all impacted with sarcoidosis through advanced clinician education, community outreach initiatives, and local peer-to-peer led support programs. Here you will find the current list of our FSR Global Sarcoidosis Clinic Alliance members, including Inova and Medstar, from which our 2 extraordinary speakers today hail. If you would like to learn more about the Alliance or would like to have us speak to your local institution, please reach out to us at info@stopsarcoidosis.org. FSR has extensive opportunities to volunteer and get your voice heard. Here you see just a few of our incredible volunteers who have gotten out into the community by hosting walks and fundraisers, engaging through community education exhibits, running presentations, serving as invited speakers, talking to legislators, and so much more. You can learn more about the many different ways you can volunteer by visiting the page link listed in the chat. If you are new to your journey or have a new sarcoidosis manifestation, FSR's Patient Navigator program with one-to-one peer support might be for you. To learn more about the Navigator program or how to become a navigator for others, please visit the pages in the chat. FSR is also continuing our efforts to improve the lives of Black patients impacted by sarcoidosis through our Ignore No More campaigns. Through the launch of our new Coalition for Clinical Trial Equity as part of the Ignore No More campaign, FSR is partnering with leading institutions and other nonprofit organizations to find practical, innovative, and transformative solutions to improving access to clinical trials for all. Join us next month on September 17th at 4 p.m. Central Time for our next webinar, New Therapies in Sarcoidosis, Helping the FDA to Understand the Needs of Those Living with Sarcoidosis. During this important webinar, you will learn more about our upcoming patient-focused drug development session with the FDA and ways that you can help to make it possible for better therapies to be developed to meet your specific needs. Please find the registration link in the chat. And please save the date for our externally led patient-focused drug development meeting, which will take place on October 28th, virtually. We need everyone, patients, doctors, nurses, researchers, to help the FDA understand why we must get better therapies for sarcoidosis now. And finally, please plan to cheer on 5 members of our community, including a board member living with sarcoidosis, who will be running the New York City Marathon to raise awareness and funds for sarcoidosis. It is now my honor to introduce our 2 speakers for today, who are both founding members of the FSR Global Sarcoidosis Clinic Alliance. Dr. Shambhu Aryal, Medical Director for the Inova Lung Transplant Program and Inova Sarcoidosis Center, will speak on advanced pulmonary sarcoidosis. And Dr. Farooq Sheikh, Medical Director of the Advanced Heart Failure Program, Regional Director, Infiltrative Cardiomyopathy Program at Medstar Heart and Vascular Institute, and Associate Professor of Medicine at Georgetown University School of Medicine, will present on cardiac sarcoidosis. Dr. Aryal and Dr. Sheikh, we are honored to have you with us today. Dr. Aryal, please feel free to share your screen, and thank you.
All right. Thank you, Mary, for that kind introduction. And hello, everyone. It's a pleasure to be here to talk to you about 2 topics that are near and dear to my heart, sarcoidosis and lung transplant. So we'll begin with what advanced pulmonary sarcoidosis is, and then talk about some of the treatment options that we have, including lung transplantation. Here are some of my disclosures. Let's just move this thing away. Before I begin, I want to thank my sarcoidosis as well as lung transplant team here at Inova Fairfax Hospital, who are very supportive in what we do. And today we're going to talk about what advanced pulmonary sarcoidosis is, what is an approach, a holistic approach in treating advanced pulmonary sarcoidosis looks like, and we'll also talk about lung transplantation for pulmonary sarcoidosis. So whenever we talk about pulmonary sarcoidosis, we're talking about the most commonly involved organ in the body. About 90% of the patients with sarcoidosis have it in the lungs, and some of people with pulmonary sarcoidosis eventually end up having severe forms of lung disease, which we call advanced pulmonary sarcoidosis. And this usually includes pulmonary fibrosis due to sarcoidosis, pulmonary hypertension due to sarcoidosis, and also bronchiectasis, along with infections that can cause a significant amount of problems. When you look at the impact of lung sarcoidosis overall, this picture shows a rough estimate of what we're looking at. So about half the people with pulmonary sarcoidosis have bothersome disease. In about half of the patients, which often overlaps with the ones with bothersome disease, there is persistent disease. And about a third of those go on to develop progressive disease, and about 10 to 30% of all have scarring disease of the lung or pulmonary fibrosis. And in a proportion of them, it leads to significant impairment as well as other comorbidities, and in some cases, death as well. When we're talking about treating pulmonary sarcoidosis, we usually take into account several factors. Because the treatment of sarcoidosis can be difficult and comes with many side effects, we're looking to treat. When we're looking at treatment, we take into consideration how symptomatic patients are, what organ function, and how much of it is impaired, what are the organs that are affected, and such. And eventually, with the patient in the mix of this very important decision, we make a decision to treat. Now, when we're talking about, and this is a table that I use whenever I'm thinking about beginning treatment in my patients. I look at the burden of your symptoms, but also what are the danger to the different organs that you have because of sarcoidosis. So if there's a lot of symptoms and a danger to organ, we definitely treat. But in other cases where there's no danger and the symptoms are little, we can choose to observe. Oftentimes, advanced pulmonary sarcoidosis will fall into this red box here, and sometimes in these two yellow boxes. But treating pulmonary sarcoidosis, or sarcoidosis in general for that matter, needs to take into account several factors. But this is a nice picture here that shows a holistic approach to take care of patients with advanced pulmonary sarcoidosis. And this is probably the single most important slide of this talk, because it sums up all the important treatment modalities that we can employ to treat advanced pulmonary sarcoidosis. It is not only medications to treat the different conditions, but very importantly, having a good, timely, and confident diagnosis of your condition, but also having an awareness like FSR is doing. We want to involve friends and family and support groups like many of you are involved in, provide you with psychological and spiritual support, but also supportive therapies like pulmonary rehabilitation, which has been shown to improve endurance as well as survival in many lung conditions, including sarcoidosis. Supplemental oxygen for people who need supplemental oxygen to maintain their oxygen saturations. Symptom relief is important, because in many cases, we may not be able to change the scarring in the lungs, or the advanced problems that the sarcoidosis is having, but we can certainly help relieve symptoms. And then treatment, of course, there are multiple drugs that are available for these different kinds of advanced pulmonary sarcoidosis. And so in the interest of time, we cannot go through all of them. But of course, the last thing we want to make sure is, for patients who qualify for a lung transplant, we definitely want to look into the possibility. In some cases, that's not possible, and palliative care and end-of-life care is extremely important. Although there are no definitive studies in the role of palliative care in advanced pulmonary sarcoidosis, there is a very important study in patients with lung cancer where palliative care combined with treat chemotherapy actually improves survival compared to chemotherapy alone. So I think the role of palliative care in treatment of conditions like this is very important. Now, this is a very complicated slide here. This is meant for physicians and medical providers, but this is an algorithm that we follow while we're trying to identify and treat advanced pulmonary sarcoidosis or sarcoidosis in general. What we're basically looking at stratifying the risk of patients into those 4 boxes. And depending on that, we look into the different kinds of medications that we're able to use to treat the disease. But at the same time, assessing for other conditions that come together with advanced pulmonary sarcoidosis is extremely important. And also, it's important to personalize treatment in every patient because no 2 patients are the same. We also look into potential new therapies, including clinical trials that are being developed and with much enthusiasm currently in the field of sarcoidosis. And what's even more important is the importance of a multidisciplinary approach. Because patients with sarcoidosis have a lot of organs that can be involved, it's really important to get different specialists into taking care of sarcoidosis patients. So here are the different specialties that are generally involved in taking care of you as a sarcoidosis patient. And to us, always the patient is in the center of care. And many centers like ours have a multidisciplinary team that takes care of sarcoidosis patients. We meet monthly to discuss some of the more complicated cases, and that really helps in taking good care of our patient population. I also wanted to highlight the importance of comorbidities. Basically, it means the other conditions that you can have in conjunction with advanced lung sarcoidosis. So these could be things like cardiac sarcoidosis that Dr. Sheikh is going to talk about, but also side effects of medications, including weight gain and bone thinning. But when you look at the number of other diseases that you have besides pulmonary sarcoidosis, the more number of diseases that you have, the more you're likely to suffer, both in terms of how long you live, but also what your quality of life is. So it's really important to take into account the other conditions that you may have in terms of treatment. So with that, let me switch gears and talk about lung transplantation, which is a major thing that we are a therapeutic modality that we use in treatment of certain patients with advanced pulmonary sarcoidosis, but also many other forms of end-stage or very advanced lung disease. But what lung transplantation is it is a life-saving procedure for patients with advanced lung disease not responsive to medical therapy, and it improves survival. It is meant to improve survival, but also we want people to survive and thrive. So we also have a good quality of life with lung transplant, as with many of these other treatment options. As a small cartoon that shows how lung transplantation is performed. This is more for medical providers. Here's a nice graph from the International Society of Heart and Lung Transplantation that keeps tabs of how many lung transplants are done every year in the world. And as you can see here, these different shaded areas show different conditions for which lung transplant has been performed over the years. So 1980s is when really lung transplant took off. And since then, as you can see, it has really taken off, and a lot of transplants, close to about 5,000 transplants are performed every year in the world for a variety of conditions. When you look here, you don't really see sarcoidosis in this graph, and that's because sarcoidosis is a very small fraction of this one particular condition called interstitial lung disease. If you look at overall numbers, about 100,000 of transplants, lung transplants have been performed since the 1980s in the world. About half of them, or just over half of them, have been performed in North America. And then about a third of all transplants are for something called interstitial lung disease or lung fibrosis. So, but when you look at the fraction of sarcoidosis patients that receive transplant out of that, so out of all the patients who get transplanted, that's just about at 2.5%. So it's a minority of patients who get transplant, but it's important because we're talking about sarcoidosis in here. But lung transplant is a really complicated process. There are several steps that are involved. It starts with a referral of patients to us, to the transplant center. You undergo a very long, lengthy process to make sure you don't have severe sarcoidosis in other organs, and eventually you get listed for transplant, wait for a little bit of time, and then get a transplant. We're generally looking for patients who have a high likelihood of death in the next 2 years without a transplant, but also a high likelihood of living 5+ years with a transplant. So those are the two conditions that we're looking when we're trying to identify people for lung transplant in general. With sarcoidosis, it can be a little challenge to identify patients, but these are some of the factors we're looking at. We look at your lung function, how symptomatic you are, what your lung disease, how quickly it is progressing, and how you responded to other therapies. But also, have you had any other complications like coughing up blood, severe infections, collapsed lungs, and things like that. The workup for lung transplant can be pretty extensive. There's a lot of testing involved, including imaging, blood work, meeting a lot of team members, and it's a collective decision, and making a decision to offer someone the chance of a transplant or not, because in some patients, transplantation may not be possible because patient may not, we're fairly certain transplantation patient may not be able to withstand a transplant or recover from it. And then it really doesn't become the right decision. When patients go on to the list for lung transplant, everybody has a score called the lung allocation score. This has changed over the years, but as of last year, March, a new system came into effect, taking into account many of the factors that had been used for almost 20 years. But this has been designed to really help the sickest of the sick, and it's really helped us transplant people on time and also improve outcomes. But it's really important to be referred for transplant on time, and that's why we're having a webinar like this, because if you look at the data of patients who were referred for lung transplantation about 3 years ago, and what happened to them 3 years later, only about 80% of them had been transplanted. About almost 10% of them were either removed from the list or had passed away without getting a transplant because they were too sick. So there is a real possibility of not being able to make it to transplant, even when you come to a transplant center. So that's why it's important to have to come to a transplant center for assessment early on. And there was a paper not too long ago out of some European centers that said people with sarcoidosis tend to have a higher chance of dying while waiting on the list for lung transplant than other conditions. So it's really important, again, to be referred for lung transplantation on time. When you're looking for donors, these are some of the criteria that we're looking to look for donors for lung transplant. But these criteria, the so-called ideal donation after brain death donors, are only a minority. They're the tip of the iceberg. So we really we're looking at ways to expand the donor pool, and these are what we do. We are able to take sometimes slightly older donors as long as the lungs are good. We're also taking lung donors that may have hepatitis C, because that can now be cured. We also use some novel technologies to rehabilitate some borderline lungs, so we can use lungs that would otherwise be not usable. Here's a paper that we published in a prestigious journal of lung diseases just early this year, actually. And what this fancy picture is showing is patients with sarcoidosis compared to all the other indications for lung transplant. They tend to go into a transplant with much higher tissue injury in the body. So that's why recovery from transplant for sarcoidosis patients might be a little protracted, and that's important to note. And again, it's for that reason, being referred to transplant on time and to a center with experience is going to be extremely important. Here are some of the considerations that are unique to the treatment or a transplantation of sarcoidosis patients. Because other organs can be involved, including heart, it's really important for us to evaluate those organs for significant involvement, because sometimes people may need heart and lung transplant or some other organ transplant along with the lungs. The surgery is often challenging because many of you will have a lot of inflammation and scarring in the lungs, and the lungs are stuck to the chest wall. That increases the risk of bleeding. And also the lymph nodes are large, and taking them out might be a little challenging. And some people also have a high blood pressure in the lungs. So all of these slightly increase the risk of having some complications around the time of transplant, including some infections. So that's why our surgeons are very cautious about patients with sarcoidosis undergoing transplant. Meaning, they're extra careful in taking care of those patients. And then because of the risk of infections, we also are very aggressive with treatment of infections around the time of transplant. And many patients with sarcoidosis will need double lung transplant, especially if they have really high blood pressure or pulmonary hypertension or recurrent infections or fungal infections. Mycetoma is a fungal infection ball in lungs. So those would require a double lung transplant as opposed to one lung transplant, which can be done in some cases in patients with sarcoidosis. And as I said, some people need a double lung transplant, but most of the time, or lung transplant with heart transplant, but most of the time we're okay with lung transplant alone. If you look at, again, this fancy graph, it's just what it's trying to show is, so initially, this kind of gold line shows the course of people with sarcoidosis after lung transplant. So it's similar to what people with pulmonary hypertension have. So initially, it's a little rough. It might be a little rough, but if you get through that first month or so, and then you actually have a good chance of living a longer life than many other conditions that people with lung have been transplanted for lung transplant. Many complications, both in the lung and outside, can occur after transplant, and in the interest of time, we won't go through those. But these include like pneumonias and rejection and airway narrowing, blood clots. And also, you can also have a lot of other bumps along the road, including complications in other organs like diabetes and kidney damage, heart disease, and things like that. So I always tell my patients, lung transplantation is not a cure. It's really an exchange of a fatal condition with another complex set of medical problems which we're able to manage. But with appropriate management, you do have a good quality of life and a better chance of living longer. So in summary, advanced lung sarcoidosis is associated with significant, impairment in quality of life and an increased chance of dying. So management requires a very holistic approach involving a lot of treatment options, including lung transplantation, which is rarely done, but is associated with excellent long-term outcomes. And with that, I thank you for your attention. And I will next invite my colleague, Dr. Farooq Sheikh, to talk about cardiac sarcoidosis.
Dr. Sheikh, I think you're on mute.
My apologies. I thought I had unmuted. Thank you so much. Dr. Aryal, thank you so much for the transition. And I thank Mary, Tricia, Mia, and the FSR for this kind invitation. Let me share my screen. Can you see my slides?
Yes, we can.
Wonderful. So thank you once again for the opportunity to speak on this topic that's near and dear to my heart in our program, the Advanced Cardiac Sarcoidosis Management Strategies. It's exciting to hear Dr. Aryal speak, who has done amazing things across the Potomac River at Inova. We're proud of him because he's also a graduate of the Medstar Health program. And so congratulations to him on a wonderful presentation. Over the next few minutes, roughly 20 minutes, we will talk about the following topics. One, we'll provide an overview of cardiac sarcoidosis evaluation and management. We'll explore the contemporary outcomes of cardiac sarcoidosis patients receiving advanced heart failure therapies. And we will once again reiterate what Dr. Aryal just stated, which is the importance of a multidisciplinary team approach in the care of cardiac sarcoidosis patients. Some basic facts worth mentioning for discussion and set the stage for the next 20 minutes. One, clinically overt cardiac sarcoidosis occurs in roughly 5% of all sarcoidosis patients. Published data from both the United States, North America, and Europe highlights this reality, which is that patients with other forms of sarcoidosis, there is unfortunately a 1 in 20 chance that they might develop cardiac manifestations. But if we do a more deep dive, either through advanced cardiac imaging, such as cardiac MRI, or sadly for those individuals who might succumb of various illnesses, including sudden cardiac death, actual cardiac involvement is identified in 1 out of every 4 patients. Many of them are asymptomatic. With the advent of advanced cardiac imaging tools, specifically FDG PET imaging, as well as MRI, we are increasing our yield of diagnosis, which allows us to really move towards a more prescriptive and prophylactic strategy so as to prevent adverse events, which is very exciting for those of us who have participated in this field for a number of years. Additionally, another very challenging and humbling aspect of the disease is that you might actually be identified with sarcoidosis where it is only isolated within the heart. And that, there are some estimates, it's a broad range of estimates, but sometimes that can be as high as 1 in 5 and maybe even higher. And those cases are particularly challenging in the way in which we make the diagnosis. Here are manifestations or presenting manifestations for patients who might develop disease. This data comes from Finland, obviously in Europe. Very impressive data published in the European Heart Journal, which highlights that the most common way in which patients will present with cardiac sarcoidosis remains heart block, electrical conduction disease, shown here in this graphic from that paper, where more than 40% of patients develop some conduction disease known as AV block. Heart failure is another leading cause of or presenting manifestation. And unfortunately, sudden cardiac death or aborted cardiac death related to arrhythmias can also be a manifestation. And so our goal is to prevent all of these complications. Our goal is to make sure that we identify people early in the disease state so as to prevent some of these complications. But these may be ways in which you in the audience today or listening in a future listening session of this recording might ask yourselves, what does my EKG look like? Do I have evidence of heart block? Is that a sign that I might have asymptomatic cardiac involvement? That's a way in which you may be proactive in your care so as to advocate with your clinicians some screening for the disease. What do we know about cardiac sarcoidosis risk, particularly for those individuals who have a prior history? One shown here on the top left, and this data is very provocative data from Denmark. Nearly 12,000 sarcoidosis patients were identified in their national registry, and they compared those patients to nearly 50,000 patients who had similar age, similar demographic, and other comorbidity background, and asked the following question over the subsequent 10 years, where the average follow-up time was more than 8 years. What is the risk of all sorts of cardiac problems, including the risk of heart failure, which in this Kaplan-Meier curve demonstrates that there is a significant increased risk for sarcoidosis patients to develop heart failure relative to control group. There's also an increased risk of atrial fibrillation and, unfortunately, an increased risk of mortality, particularly focused on the heart failure aspect. Shown here on this forest plot on the right is the reality that our sarcoidosis patients are at increased risk for heart failure. And that in addition to that, shown in this central diagram from a review article, that the reality is that the heart failure disease state is a more progressive disease state with a higher mortality than those patients without sarcoidosis. And so shown on the left is the idea that a granuloma, which is at the center of the diagnosis of this disease, is related to our immune system, how it responds to environmental cues as well as genetics, and that, as we know, any organ can be involved. But because of advanced imaging, particularly MRI and PET imaging, we are more increasingly recognizing sarcoidosis-related cardiomyopathy and the development of cardiac sarcoidosis. The hallmark of this, of course, is inflammation. Our goal is to prevent the adverse effects of inflammation, specifically the formation of scar. As we'll talk about in an upcoming slide, we use steroids and other strategies to deal with that, to quiet down the immune system. For those patients who progress and develop heart failure, typically the way in which that is identified is in an enlarged heart, which we refer to as a dilated cardiomyopathy. If you are not familiar with the word cardiomyopathy, just as it might sound, cardio is heart, myo is muscle, and pathy is disease. So this is a disease of heart muscle. And the classic presentation is a dilated heart with weakened heart function, which we measure by a measurement known as ejection fraction. But rare, there are individuals, maybe 5%, probably a little less, who present with heart size that is normal, with thickening of the walls of the heart, which we refer to as a restrictive cardiomyopathy. And they have similar symptoms of breathlessness, fatigue, swelling, particularly in their legs and abdomen, which limits their quality of life. Our ultimate goal with the use of treatments for heart failure that are highlighted here, drugs such as beta blockers, sacubitril valsartan, categories of drugs known as MRA and SGLT2 inhibitors, and in appropriate patients, device therapies, including defibrillators and pacemakers, is to prevent the end-stage heart failure state, which can be manifested by heart failure, but also arrhythmias. But there's great hope if, God forbid, you do develop that, because the reality is, as I'll show you in the upcoming slides, there's incredible promise and benefit to be gained by heart transplantation and LVAD therapy, which can, one, improve survival, and I would say 1A, improve the quality of your life through the care of a multidisciplinary team. The treatment of cardiac sarcoidosis does require a multidisciplinary team because it's a complicated treatment strategy. As you heard from Dr. Aryal, and you've heard from other leaders in the field through your own personal journey, either through websites and advocacy groups like FSR, as well as your own reading of the medical literature, you recognize that you and your families have the challenge of this multidisciplinary approach for treatment, which involves immunosuppressive therapy, which we'll talk about in greater detail in a second, the management and prevention of heart failure, but if you do develop symptoms, how we treat that, the risk stratification for sudden cardiac death, particularly the question of whether or not one might benefit from the implantation of a defibrillator or therapies like that, and then monitoring for other electrical problems. Shown on the bottom right is a graphic that highlights the various treatment strategies in terms of immunosuppressive therapy that can be used to treat cardiac sarcoidosis. And it is a very exciting time in the history of the diagnosis and treatment of sarcoidosis, because we are in the midst of, and very soon to have, the first randomized published data regarding the treatment of cardiac sarcoidosis with treatments such as corticosteroids, particularly prednisone, compared with the addition of methotrexate in a steroid-sparing agent, which is in this graphic from a review article in 2020, considered a sort of second-line therapy. But many times programs like ours employ these quote-unquote second-line therapies up front so as to shorten the duration of corticosteroid use, prednisone use, to avoid some of the adverse effects of that drug. And then for those patients who do not benefit from these first and second-line therapies, there's a great deal of promise with tertiary therapies such as TNF-alpha inhibitors and other agents, which are beyond the scope of today's discussion. What do we specifically look for in our patients? And it's such an exciting time in the field because there's so many clinicians, in no particular order, internists, our APPs, our nurses, and all of our clinicians across the healthcare system were thinking about this disease. And I just want to remind you that any one of you in the audience may benefit from the care from all of the members of the multidisciplinary team, because they may be looking out for these types of complications. One, conduction disease, again, heart block, various forms of heart block. Two, tachycardias, the medical term for fast heart rates, which can originate from the upper chambers of the heart, known as the atria, which we call a supraventricular tachycardia, or then the more feared fast heart rate known as a ventricular tachycardia, which usually is treated with either drugs to suppress it and or in concert with a defibrillator to prevent the adverse effects of it. And then the cardiomyopathy that we mentioned, which we'll now explore in greater detail. So what are the treatments of cardiomyopathy? And I appreciate Dr. Nisha Galotra, my partner and colleague at Johns Hopkins, was kind enough to share this slide with me, and I appreciate her charity in this regard. Guideline-directed medical treatment, which we call GDMT, refers to in patients with a reduced ejection fraction 4 categories of drugs. Those FDA-approved beta blockers, known as metoprolol succinate and carvedilol, ACE inhibitors, ARBs, and sacubitril valsartan, otherwise known as ARNIs, which is specifically a drug whose trade name is Entresto, aldosterone antagonists, and SGLT2 inhibitors. These serve as the 4 pillars of heart failure treatment for those individuals whose ejection fraction is reduced. We use diuretics not to improve survival, as these preceding 4 drugs have been shown to do, but rather to improve quality of life and relieve symptoms of heart failure, most notably shortness of breath and swelling, otherwise known as edema. So they're very beneficial. As we'll show you, these drugs actually have been beneficial in patients with heart failure, reduced ejection fraction, and based on extrapolation, we have every reason to believe they will be beneficial in all of our sarcoidosis patients who fulfill the criteria for their use. Rarely the disease progresses, and unfortunately in some of these patients, the evaluation for advanced heart failure therapies is employed because we cannot relieve our patients' adverse quality of life features, or they have features to suggest that unfortunately their ability to survive the disease in an advanced form is limited, which was highlighted by Dr. Aryal as he reflected on advanced lung disease. And this is where we think about transplant, left ventricular assist device, the acronym known as LVAD or heart pump. And let's spend a few minutes talking about these therapies. Before we do that, let's talk about some optimistic data. This data published from Johns Hopkins really highlights the reason why we should remain very glass half full and optimistic when we make a diagnosis of cardiomyopathy related to sarcoidosis or cardiac sarcoidosis. Shown here in the graph on the right are patients who presented in the x-axis on the bottom in 3 groups: those with an ejection fraction less than 30%, those with an intermediate ejection fraction defined as 31, or let's say 30 to 49%, and those whose ejection fraction was equal to or greater than 50%. And then the question was asked, what happens to them over a period of time? 82%, so 4 out of every 5 patients had an either stable or improved heart function over the period of observation. And there was a group of people who didn't necessarily benefit, and those were the ones who at the initial diagnosis had a very reduced ejection fraction or had forms of heart block. They didn't get as much benefit after treatment, but that doesn't mean that we should stop trying. And this study, which concluded at 1 year, has not looked at long extended periods of observation. And the Medstar Health team is actually actively researching this now to see what happens over an extended period of time. For those patients who do not garner the benefit of these medical treatments and device treatments, heart transplantation and left ventricular assist device can be employed. And it's important to reflect on the reasons why. One, for heart transplants, it's indicated for those individuals with an advanced form of heart failure. The medical term for that is end stage, though it's not a phrase I like very much. And then another one, refractory arrhythmias. So those people who, no matter what we do, we cannot quiet down the electrical disturbances of the heart. And despite all the treatments, interventions we've tried, they have not been able to be quieted down. The good news, as we'll show you on the next slides, is the outcomes for these patients with cardiac sarcoidosis who receive both heart transplant as well as left ventricular assist device are really equivalent to those individuals who have other forms of end-stage heart failure, which is great news. Left ventricular assist device is really important. Roughly 3,000 to 4,000 patients a year receive this therapy. This is a surgically placed battery-operated mechanical device, which is shown in this cartoon here on the right, where the device is embedded within the chest. So this is through a sternotomy, a cardiac surgery, and this device sits in concert with the heart, working in parallel with the heart to improve blood flow in the body that's failing because the heart is failing, which can then improve patients' symptoms of breathlessness, their ability to walk and ambulate, and improve their kidney and liver function. It does require electricity and a computer to sort of manage this therapy. So there is that one sort of disadvantage, which is there is a wire, a driveline that extends out of the skin. But as I'll show you in data that's on the next slides, there's every reason to believe that a great quality of life can be gained. And the current published data with left ventricular assist device therapy is people are able to live more than 5 years with the therapy, which can be used both as a bridge to transplantation or for longer term therapy. So what's the risk of developing an advanced form of heart failure with cardiac sarcoidosis? In other words, you sit there and you ask yourself, my God, I've been diagnosed, and the clouds are above you and you're down in the dumps. But we should reflect and remember the survival with cardiac sarcoidosis is actually quite good. 5-year, 10-year survival shown on the left curve, Kaplan-Meier curve, is actually it's really good, 96%, 86%. Yes, some percentage of patients do require transplant or LVAD therapy, so that number drops. It's 92 and 78% for those who do not require an advanced heart failure therapy. But again, estimates are only 0.5 to 9%, less than 1 in 10 individuals with cardiac sarcoidosis are going to develop an advanced form of disease requiring a therapy. So we must remain connected and optimistic that we can help you prevent the development of advanced heart failure. Things that might actually be prognostic factors. One is the extent of involvement. 2 is the type of presentation. When you first present with the disease, particularly ventricular arrhythmias, portend that chances are you will one day need a heart transplant if that's how you presented. And then how we diagnose it. In the definite population, which is a definition based on the Heart Rhythm Society definition, there is a signal for potentially an increased risk for developing advanced heart failure. What about the contemporary outcomes of cardiac sarcoidosis patients receiving advanced heart failure therapy? And it's a good way to sort of conclude our talk because it's very optimistic. One, we are excited, data from Dr. Galotra and her team at Johns Hopkins, shown here from a figure in that paper, highlights that over time, we are identifying red is LVAD patients, blue is transplant patients, more and more patients receiving the therapy over the period of observation. And that number is increasing over time because more and more patients are being diagnosed with this disease. We at Medstar led an analysis from the National LVAD Registry, which asked the question, in patients with sarcoidosis, what are their outcomes relative to those patients who do not have cardiac sarcoidosis, particularly a group of people with a disease known as idiopathic dilated cardiomyopathy. So on the graphic shown on the left is a Kaplan-Meier curve. On the x-axis, we highlighted and identified over the period of observation 86 patients who had cardiac sarcoidosis and compared them to nearly 6,000 patients who had idiopathic dilated cardiomyopathy, which refers to a group of people who have an enlarged heart where we don't know the cause of the weakness of their heart function. And shown here is the survival probability over the period of 2 years, where we demonstrated there is no difference in survival between the two groups, which is very exciting. There was some patients in the early, meaning the first 3 months after LVAD therapy, where there were some risks of some reversible complications, but the long-term risks over 3 months, greater than 3 months, known as the late adverse risk profile, was no different for sarcoidosis patients relative to those without cardiac sarcoidosis, which is wonderful news. At our center, been a labor of love and an incredible journey for us. We have one of the nation's largest LVAD programs. And in that program, we identified a number of patients who have had cardiac sarcoidosis, those with definite, probable, and possible cardiac sarcoidosis. And to date, more than 40 patients in the history of our program have received LVAD therapy. Many of them have gone on to transplant. What's fascinating, oops, I did it again. What's fascinating is that 7% of all of our non-ischemic cardiomyopathy patients actually eventually we made a diagnosis of cardiac sarcoidosis. So that begs the question for those patients who are out in the community who have been ascribed this diagnosis of non-ischemic cardiomyopathy, how many of them may actually have a diagnosis of sarcoidosis? And in the most recent cohort, meaning 39 patients with sarcoidosis relative to our non-ischemic cardiomyopathy population, we found no difference in survival, no difference in adverse events. with major benefits in quality of life, something that we are planning to publish here very shortly. In transplantation, the story is equally optimistic in our patients with sarcoidosis, shown here in two curves. On the left is survival, overall survival, and then freedom from the heart failing, known as graft failure. Dr. Galotra and her team at Hopkins identified wonderful 1 and 5 year survival and no difference in the freedom from graft failure, which is wonderful news. And a more recent analysis from a team at Northwestern, advanced heart failure team there, highlights that survival is no different between the groups in these boxes I've created here on the right. And it didn't matter what era you lived in, the survival was equivalent, that they also were able to prove that there is no increased risk of graft failure. But very exciting was that the risk of the heart rejecting appeared to be less for sarcoidosis patients. The risk of infection appeared to be less, and the risk of malignancy was no different for patients with sarcoidosis relative to those with other forms of heart disease requiring transplantation. What about the holistic approach in the care for our patients? I became a doctor to think globally about the patients, not just to focus on the hearts. So to think about how the psyche is being affected by their disease, how all of the organs of their body are being affected by their disease. And I think no team encompasses that process better than our palliative medicine team. And the World Health Organization defines palliative care as an approach to improve the quality of life of our patients who have serious illness, because we are interested in relieving suffering through early identification, assessment, and treatment of all sorts of problems. And which one of us who have taken care of sarcoidosis patients, have been blessed to care for their families, have not felt the burden of our patients who recognize that we might treat their cardiac sarcoidosis, but they have fatigue, they have insomnia, they have erectile dysfunction, they have other comorbidities that are affecting their quality of life. And so the journey we went on here in our multidisciplinary team was to make sure that we thought holistically about the care of our patients. And to that effect, we actually embedded within our team a palliative care team. And this was an incredibly exciting endeavor now over the past decade, where the palliative medicine team, I'll show you all the members of the team here shortly, became part of our heart failure program and saw all of our patients. And they saw them in outpatient settings within the Cancer Institute, as well as the Medstar Heart and Vascular Institute. And then they created a virtual platform known as the Patch Program to meet our patients at their homes virtually, like we're doing today. And this group consists of clinicians, both physicians, advanced practice providers, APPs, both PAs and NPs, pharmacists, social work, individuals of religious faith, including chaplains, who work on all sorts of clinical challenges that our patients face, because we respect and recognize the need to help our patients with all sorts of extra cardiac manifestations of disease. So in summary, cardiac sarcoidosis is an increasingly recognized cause of heart failure for which treatment requires a multidisciplinary team approach. We also recognize and are excited to point out that advanced heart failure therapy outcomes in cardiac sarcoidosis patients are similar to non-sarcoidosis patients. And just finish with a quote, recognizing what you already know, but for a disease that has been described in the modern world more than 160 years ago, very smart people, smarter than me, thought about this 80 years ago. Dr. Longcope from Johns Hopkins wrote this and said that this has to be taken seriously. This is not a rare disease. And we look forward towards pushing the envelope towards eventual cure for this disease. Thank you for the time.
Thank you so much, Dr. Sheikh and Dr. Aryal. And Dr. Aryal, and I'll invite you to turn your camera back on. So we did receive many questions from those of you in the audience in your registrations, and we have also received a number in the chat. So I'm going to jump right in just to allow some of these questions to be answered. And so I'll go back and forth between you, and there's definitely a few for both of you, and we'll see how many we can get done here in a few minutes. Dr. Sheikh, can people with oops, I was reading the wrong one there. Oh, no, Dr. Sheikh, for people with cardiac sarcoidosis who have more advanced forms, can they anticipate to live a normal life?
Thank you so much for the question. We'll have to define normalcy. Obviously, I want to be careful with that terminology. It is a disease that we all recognize in advanced forms of cardiac sarcoidosis. We are going to strategize. One, can we prevent or can we improve the quality of life without needing a heart transplant or an LVAD? But if we do need that, then there are, shall we say, trade-offs, meaning we're going to be taking certain medications to protect the transplanted heart, the frequency of visits to our clinicians. But the reality is that the improvement in the quality of life of the individual, in my experience, taking care of hundreds of transplants recipients, of which in the last 4 years, I think we've transplanted more than 20 patients with sarcoidosis in that period of observation. Patients regularly, routinely highlight their quality of life has improved. And like every other disease, there's a bell-shaped curve. Some people are truly, they see us once a year, they're doing amazing, they don't require a lot of care. But for others, there is still regular interface. And so I think the ultimate thing I would say is there should be a focus on hope. There should be an idea that we can improve where you are, that you do not have to be burdened forever by the severity of your disease, and that we can improve your station in life. But I think it would do anybody a disservice to say it's normal. I don't know what normal is anymore. I'm not sure if my life is normal, but the point ultimately is that I think we can improve your quality of life. And the programs that have been highlighted here, appreciative again of the invitation, are the types of programs that can help come up with a holistic approach.
Fantastic. And Dr. Aryal, there were a lot of questions around the concept of stage 4 pulmonary sarcoidosis and questions around whether that means that it is a terminal diagnosis. Can you say a little bit more about what stage 4 pulmonary sarcoidosis is?
Absolutely. First of all, thanks for whoever brought that question up. It's a really important question. And then one of the first things I want to say is the staging of sarcoidosis is totally different from cancer staging. So this staging system was developed close to 150 years ago based on X-ray patterns. So if you have just lymph nodes in the chest, that's stage 1. Stage 4 is primarily all, lungs have a lot of scar on them. And then it is helpful, and we still use it in the medical world because, if you just have stage 1 disease defined as just the lymph nodes in the chest, there's a high chance of spontaneous resolution. The disease can go away by itself in the lungs, at least. And stage 4, by nature, by definition, because of the scarring, does not go away. Having said that, I follow a lot of patients here in my clinic who are stage 3 and 4 by that definition, who have very minimal symptoms. And on the other hand, I have many patients who are stage 1, but they may have debilitating cardiac or neuro disease. Don't pay attention. I was just not paying attention to that stage 1 or 4 in your chart. That's more for medical providers kind of get a sense of understanding. But in general, stage 4 is advanced pulmonary sarcoidosis, and you might want to look into talk with the providers whether you need to go be evaluated for high blood pressure or pulmonary hypertension in the lungs, or potentially consideration of transplant if you're symptomatic, and obviously if the disease is worsening.
And Dr. Aryal, I'll have you continue. We received questions for both pulmonary and cardiac, and so Dr. Sheikh, I'll have you chime in after around what are those best tests that patients should be paying attention to or talking to their doctor about to make sure that they are identifying challenges with their organs early enough for being able to be part of transplant.
Yeah, so because it's a multi-system disease, can affect any organ, I think as a patient, you should be aware of the different symptoms that sarcoid have in different organs. And then these are generally, that's why our questions to you in clinic are geared towards that. But also, depending on the organ that's involved for you, we gauge your symptoms, but also do X-rays, imaging techniques like CT scans, MRIs, and certain blood tests, what we call biomarkers. So all of those are put together in determining what the disease is doing. And sarcoid's a funny disease. For example, when you look at some other cases of scarring lung diseases, your lung function and your CT scan, your symptoms kind of go hand in hand. You have a worsening in the CT scan, your lung functions drop, and then you're more symptomatic. With sarcoid, we see all sorts of dissociation. You may have a lot of nodules, and your lung function may actually be better, and you might be feeling all well. So it's a challenging thing, and then that's why it's so important again to put things in perspective, utilize a multidisciplinary approach to taking care of you. So it's so important to have a regular follow-up.
Great. And Dr. Sheikh, any thoughts around the tests that people should be thinking of and the conversations they should be having with their doctors with regard to cardiac sarcoidosis?
I would make a relatively strong argument that one of the questions that should be asked for a multisystem disease at any point in any station of the disease is how many organs are involved. So if we're going to ask that question for cardiac involvement, an echocardiogram in and of itself, pictures of the heart known as an ultrasound, will not be sufficient to exclude cardiac involvement. So you cannot be reassured that if my echocardiogram is fine, everything's okay, because the statistical data regarding the ability to make that diagnosis of cardiac sarcoidosis is unfortunately not sufficient. So tests like MRI of the heart are useful to identify for a signal of cardiac sarcoidosis. In the proper patients where treatment for an inflammatory aspect of sarcoidosis, where there's inflammation in the body, might be entertained or considered, whole body fluorodeoxyglucose, known as FDG PET scan, which should at the proper centers also involve cardiac imaging, I think would also be very important. If you've established a diagnosis of sarcoidosis, Tricia, and to whoever asked the question, then the question becomes, is the disease being properly treated to avoid longer term effects? And I think in general, what I would say is, centers like Dr. Aryal's and I, because we work so collaboratively, it's nice, and this is a shameless pitch to the FSR, who's had these global alliance partners. These are the centers that put team members together. So the chances are that if you have the disease and you go to one of these centers, they are going to very rigorously look in totality at the disease. It doesn't mean it can't be done by our physicians who are passionate about the disease, who are treating patients in the local communities, because that is an incredibly important relationship. But I would say either through, again, mechanisms by the FSR or others, you can get sort of expert opinion as to how to be evaluated, because part of the sort of devil in the details is the individual symptoms that are currently manifest and or the disease in total. So I think to answer beyond that might do people a disservice.
Great, fantastic. And I know we're coming up on time and there's so many more questions. So we do promise the community that this will not be our only time to address these questions, and we'll be bringing this forward, especially in our summit coming up in the spring, but even perhaps before then, we'll be able to have another follow-on conversation with so many great questions. But I wanted to ask you both, with regard to thinking about the future for cardiac sarcoidosis and pulmonary sarcoidosis, what is giving you hope for the future? And Dr. Sheikh, I'll ask you to start.
Thank you for the question. Good way to potentially end these questions. And again, happy to help in any way to answer questions on an offline mechanism. I think that the excitement is, number one, in no particular order, the attention the disease is getting because resources are brought to bear. Institutions, individuals, patients, and advocacy groups like the FSR are really shining a light on the disease and recognizing that for those individuals who are symptomatic, who might even have the disease or may have symptoms that are suggestive of the disease, that we really have the opportunity to connect the dots quicker than we've ever had to do before. The second is the collaboratory nature of the community, this ecosystem of individuals who take care or are interested in caring for sarcoidosis patients, whether it's clinicians, advocacy groups, industry partners, national entities. I think that's, for me, very exciting. A week doesn't go by where you don't see something in the medical literature about sarcoidosis, which is, I think, really exciting. And then finally, I find the inspiration in the patients and their families, because they're really advocating for themselves. The final thing is that the treatments and the options for treatment have never been better. And I think just making the diagnosis earlier in the disease state, irrespective of the organ, is the key.
Fantastic, Dr. Aryal.
No, Dr. Sheikh put it very aptly of all the things I was thinking of. So I don't have much to add, but just wanted to stress, the collaborative efforts that you've had within institutions and across institutions, bodies like FSR, and patient advocacy groups. And I think it's really brought light, the importance of having to diagnose this condition and treat it appropriately. And I think the other thing that I'm really excited about is there's so much of research interest in sarcoidosis currently. And for the first time, we have a phase 3 trial, at least in pulmonary sarcoidosis, that's going on. That's been, completed recruitment of patients. And so we're looking at results of those trials. So I think in the next few years, we will have much more effective treatments that are designed for patients with sarcoidosis, and really gives me hope.
Fantastic. Well, thank you both so much for your insights and your presentations. I hope that you saw in the chat, but there was very much excitement around this webinar and all the helpful information that you provided. Mary, I don't know if you wanted to join back in to close us out, but I wanted to extend my gratitude to both of you and to the entire community for joining today and all your wonderful questions, which we will continue to follow up on into future webinars as well. Mary, I'll pass it over to you.
Thank you, Tricia. Dr. Sheikh and Dr. Aryal, thank you so much. We are so very grateful to you. I know you've been busy answering questions and doing presentations, but I can assure you in the chat, it has been very, very lively with very much participation from our community and all who are offering you a big thank you, and how awesome this webinar has been and how this will change conversations for the patients with the doctors. And we are forever grateful, not only for this webinar, but you are both our champions, absolute champions in moving sarcoidosis forward and in speaking up for patients and in helping patients throughout your day-to-day extraordinary efforts. So on behalf of all patients globally, thank you so much for your extraordinary work. And again, honored to be partnering with you. And thank you to everybody who joined us today. We will share the recording through the link. We will continue to push out some additional resources that we hope will be helpful to you. And as Tricia said, we will add this continuing dialogue on for more conversation about these important topics regarding advanced cardiac sarcoidosis and pulmonary sarcoidosis, as well as other things. Thank you to all, and we hope everybody has a fabulous Labor Day weekend. Take care.
Thank you.
Bye-bye.
Thank you.